Sure. So, so, hi everyone, Raj Parikh, the Vice President of the New York Alumni Chapter. Both Pavan and I have this distinct honor of hosting the Unit Albala today. I joined the New York Alumni Chapter last year when I moved out here in New York, graduated from UCI in 2019 with majors in quant econ, data science, and math. It's been a fantastic ride so far. Totally love my time here. As we all know, we're in the middle of a pandemic, and just trying to navigate that whole transition as a young professional has been very eye-opening, I would say. And it's a pleasure to be here, and happy to talk to everyone during this event and even after. So if you have any questions, feel free to put them in the Q&A throughout the event.
And like I mentioned, my name is Pavan Lohia. I'm the chapter president here in New York. I'm class of 2017 from the program in public health, and very active alumni, both Forsyth School of Public Health and UCI as a whole. And without further ado, I'm going to turn it over to Dean Bernadette.
Thank you. Thank you. I'm really excited to be here. Thank you so much. The chat room says go UCI, and I say go UCI. So, and I appreciate very much the opportunity to be here. Last week we were supposed to do this, and I don't know if you know, it's kind of actually apropos. I'm actually in New York, although my background is beautiful Aldridge Park. I finally came back to New York after a year in beautiful Southern California, but obviously a year of COVID, and that's what we're gonna talk a little bit about today, or a half a year of COVID, I should say. But I'm finally moving to California permanently, and so I had to come back, and of course, I came back, quarantined, and of course, during the middle of that hurricane, no lights, no water. And so, you know, whatever feelings my husband and I might have had about our home in New York after going through heat wave, hurricane, no lights, no water, I have to say I'm looking forward to getting in that car and heading back to sunny Southern California. I'm a New Yorker though, through and through. You can hear it in my voice, nothing has changed. And so I'm really happy to be talking to all of you alum from New York, from California, and from all over. And thanks so much, Pavan, for being so active as an alum for public health, great program in public health. And I was actually brought in to try to transition us to a school, of course, in the middle of a global pandemic, but we've actually made a lot of progress. I came in, we were one department. We are now 4 departments, a solid program, and we are moving forward, and we are really, I think, moving public health forward, both at the university. COVID has been, you know, devastating, but for public health, an opportunity. And we've really been, all the faculty, all the students, all the staff in public health, and of course the leadership across the whole campus have just been incredibly supportive of our efforts to really, you know, keep COVID under control on the campus, and of course in Orange County as well. And I want to just give you a little perspective, my perspective, if you will, on COVID, having joined UCI and really in my first year. So very briefly, and you've all seen these curves everywhere, but this is Orange County. So Orange County is one of the first places to see a COVID case. We all know that. And so very early on, the chancellor was prepared, brought a team of people together. Public health was included. How are we going to respond to this virus? We didn't know a lot about it, and we're going to talk about that. Very much a fluid situation, still remains fluid, both in Orange County and throughout the world, really, but certainly here in the United States. And so we were on this trajectory in Orange County, and it was the same trajectory. Basically, you could fit the line for the trajectory that we had seen 16 days prior in Italy. And I know you all remember the devastating events of COVID in Italy. And we were literally on that line. And the figure on your left really looks at this trajectory of this line. And somewhere, you know, we went from hand washing vigilance to not shaking hands to social distancing, to UCI going remote, the county going remote, and California going remote. And that's somewhere around March 15th 13th, 14th, 15th. And so what happens though by March 28th, and this is so important, is that if we shift from the left to the right figure, we see that we actually do in Orange County significantly change the trajectory of growth of cases, and we flatten, not totally flatten, but we certainly flatten that growth out. And I think this is really important to remember always, that we have major, that people really have a major impact in the way that we experience diseases. This is Orange County cases. This is our UCI cases, and you can see that this is really through the end of June, though. You see this kind of increased slope till about March, 14 days after we start to shelter in place. You see this flattening, and then you see, starting around Easter, Passover, this increased growth, and then flattening, increased growth, flattening, and then this real increased growth. And if we extended this out now through July, you would start to see flattening. You can see, remember that we sheltered in place in Orange County early to halt the transmission, or to stop the transmission, or slow the transmission of disease. The other important thing that we did was we were able then to be able to realistically treat all the folks who ended up in our hospitals and in our ERs. We were able to treat them. Peak and surge, those two words that we've heard in New York, we've heard all over. Peak is when you reach this point where you have this overwhelming number of cases. Surge, same thing. They come, and it comes very quickly, and you have this increased trajectory. And the problematic thing with peak and surge is that you don't have enough resources, beds, physicians, hospitals, and we know New York, that we saw what that meant. And so we really tried in California very quickly to be able to do that. And then you can see, so I think what's interesting is that while we started to see this other peak surge over the last couple of weeks, we were still able, the governor was able to get us to step back from restaurants, to pull back some policies. And we're already starting to see, not just for Orange County, but for California overall, that we're starting to flatten again. And the other devastating thing that came out of Orange County, that came out of New York, were really like East Coast, West Coast, sisters or brothers, was this unveiling of huge race ethnic disparities for COVID. This is what we see in Orange County, and you can see over time that while this disease starts out as a disease of sort of affluent white, the first couple of weeks of disease, that this disease transitions over to being a disease of Latinx predominantly in Orange County. We just don't have the Black demographics. If we had more communities of color other than Latinx, we would see, I think, increased numbers there, and we can see that now we're seeing growth though in all different race ethnic communities, but this has been really very hard hit in our Latinx communities. I want to show you a heat density map of the growth. And so just keep looking at the screen, and all of a sudden you'll start to see some shadows. This starts in March. We're in March. You can begin to see some shadows in Anaheim and Buena Park and Santa Ana, a little bit down near Huntington Beach. And you can see this growth. We're in May now. And look at this grow and grow. We're in June. It's unbelievable. We're seeing this grow out now. We're starting in July. And we're seeing, of course, Santa Ana and Anaheim, our densest communities, really getting hit hardest, but that there is this dissemination of growth throughout the county. So even though back in March, we flattened that curve, we did not halt transmission, we simply slowed transmission. And of course, we know what happened between July 15th and we're now in early August. What are we, August 13th? That we know that we had more spread around the county. and that we ended up really seeing this almost peak, almost there, that we didn't get there. I just want to end with 2 slides, the anatomy of an epidemic. So we started out with COVID. We all did. It was an acute disease. We didn't know much about it. We tried to first do prevention, right? Wash our hands. What else could we do? Then there was preparedness. How do we prepare ourselves? Making sure that we have the reagents for testing, making sure that we have the hospital beds that we need. We were in crisis mode. We were moving as fast as we can. There was lots of information and lots of misinformation. And when you don't know about a disease, you don't know how to predict it. There were things that epidemiologists thought about then. You know what? Those things are still the same pieces of information. Not that much has changed in terms of the basics, but there were all different scenarios, lots of stuff getting thrown at people. But now, and I would say now, starting in June, we've moved, and this is like the public health nightmare, when an acute crisis becomes chronic. And when people are not wearing masks and heading to the beach in Orange County or up in LA, or, you know, deciding to go to restaurants and going out to stores and getting together in large groups, a part of that is because we're fatigued. You know, we were talking about this before we got on. We're tired. I'm tired. We're all tired. Go away. I don't want COVID anymore, right? And so we are fatigued. We are chronic. We have to figure out. And one of the things that we talk about is this concept of harm reduction. And right now we're sort of going to be living with this for a while. And I'm going to talk about vaccine in a little bit if there's questions about it, but we're going to be living with this for a while. Like we live with flu. Flu kills, 60,000 people a year. Nothing like this, but flu is something we know a lot about because we have it every year. So it's about harm reduction, doing the things that we can do, living our life as we can, and trying to do everything we can to stop the transmission of disease. But we cannot shelter in place all the time at home. I think that we've said it, we can't do it anymore. So how do we get ourselves out? How do we become more social? How do we open schools or go hybrid schools? How do we do this? And this is what we're going to need to be thinking about now, is what are the steps towards harm reduction? Anybody who's in public health in the HIV days, it was always about harm reduction, right? It was, we knew that we could halt the transmission of AIDS by being celibate, but people, but that was not being able to be our emotional and physical selves as we needed to be. So we applied a very effective harm reduction strategy. And I think that's where we really are today. Again, the fatigue, this feeling that people have dodged the bullet. We have this terrible economic hit. It's become reality. Daily ongoing challenges, all of the things I always say to people, I say to my husband, I said, what about the poor people that were forced to live together, that don't even like each other, right? And worse than that, domestic abuse, food insecurity, all of these things. So this is really where we are. And I just want to end because I think this is critically important. And that is, Mervyn Suss is a very famous epidemiologist, and he talks about societies in part creating diseases that they experience and then materially shape the way in which diseases are to be experienced. This is a virus, okay? And this virus has been experienced in every country in the world differently, and in every state in the United States differently. How can that be? Can there be that many mutations? And I would say no, because it's not the biological here, it's the social. This has become a political disease. And this is still a virus, and people are still dying. And we really have to get to the heart of the matter, that we in this country and in states across this country are shaping the way that we are all experiencing COVID in March, and now how we're experiencing it in the summer, and we're going into the winter months. And which means we have impact in the way that we live with COVID until it's no longer there. So that was sort of my opening statement. Questions, however you want to organize this, Poppy.
So thank you for that. And just diving right in, me and Raj had a few points before we take other questions. Just starting off, I think, a lot of what you said, when we spoke back in April, actually, I was thinking, of just how much things have changed. And, I think at a very broad level, what do we learn from, just our national U.S. healthcare issues that really exacerbated this? We saw, all parts of the world go through this, but the impact that the U.S. has had has been unparalleled compared to any of those countries. So really, would you say, of all the, issues that our healthcare system does currently face, were there any in particular that exacerbated where we are today?
Yeah, I think that there are three main issues as I think about sort of our healthcare system. Has it failed us? Probably more than three. But I want to talk about, I think, three critical ones and with regard to COVID. And one is that we really needed a national leadership plan on how we were going to handle COVID. We needed to look to the CDC, and they're the folks that are trained and have a lot of experience, and they've somehow been diminished in this entire, and there's a lot of reasons for that, but we needed but they all lead to sort of the failure of the United States, greatest country on earth, right? That's what everybody, that's the cry. And but we haven't seen that at all, not at all, not from the very beginning. And so I think that's been a big problem. The second is that we haven't embraced science and scientific evidence, and that science has become something like that you can either accept or not accept. And I don't know what happened there. Science is the way forward to think about how to treat a virus, okay? And scientists, people who are, again, trained to do this, who have a sense of this, this is critical. Now, I talked a lot about misinformation and information, and part of science is not just spewing results, but it's also evaluating the validity of those results. And if we had national leadership and we had key scientists that would be able to say, this is a good study, or this is interesting, but it doesn't really help us as much as we need to, so we're going to stick with the CDC guidelines from March, I think that would have helped us. And the third thing, and I've struggled with this, not just with COVID, but with everything I've done, is communication. We have not had transparent communication from anyone. And the communication wouldn't have just been about COVID. It should have been about, hey, this is new, nobody knows, we're gonna go on, it's a little roller coaster ride, buckle in, it's gonna be fluid, and we're gonna change some of the things. I have to say that in February, I'm a scientist, that the evidence really wasn't out there to suggest that we all wear masks. Now, I wish it was, because we probably would have stopped transmission of some of the cases had we known then what we know now, but it wasn't there. And so we have to evaluate that evidence. And so, but communication for lay folks, for everyone to understand the fluidity of this, to understand that the timing was not going to be short, it was going to be long, and that public health is about, and I think I've said this here or in other places, public health is about the health of the public, okay?
Right.
Nobody nobody believes in, in our individual rights and liberties more than me. But I'm a public health person, so at the end of the day, I'm going to say public health is, for me, is the priority, and for public health folks, it's the priority. So you don't want to wear your mask, stay home. I mean, I'm sorry, but my focus is is public health.
Right, the greater good, right. Oh, of course, thank
Definitely.
you. Raj?
Definitely. Thanks, Pavan. So I guess our next question would be, you're a New Yorker at heart, and then at the same time, you've been given this incredible opportunity to transform the anteater community. So you're going to go to SoCal very soon. So what are the differences in the New York approach to handling COVID versus California? We talked about the curves that we saw earlier. And so what are some of your key takeaways between the two approaches?
Yeah, I mean, it's very hard. I don't want to criticize anybody, right? So, but I will say that, maybe it's because we were only 3.2 million people in Orange County, but we took control, and maybe it's because we had the first case of COVID, but I think we anticipated, and I think we took control early in California. We took control when we were on the when we were on this upward trajectory, but we weren't so far up. And that helped us to really slow down. I think everybody expected this to start out and hit California. And I think that's why. I think nobody expected this to zip right over to New York. And so by the time that people said, oh my God, it's in New York, it was out of control. And I know that there were a few days to a week when there was a lot of debate, shelter or not, can we go or not? And unfortunately, I think those were critical days. I think that Governor Cuomo did a great job moving everybody together and getting those resources that he needed. But unfortunately, New York, for many reasons, came in a little too late. And I think that was very impactful, unfortunately.
Got it. Perfect. Thank you. Pavan, shift on the focus to you.
Yeah. So I think your
video's off.
Sorry. So I think the other question is really, do you think that states ultimately did reopen too soon? And, can we see now that we're seeing the, Midwest and the southern states really start to pick up in the number of cases, are we just exacerbating the duration of COVID overall, or, should there be more federal action throughout?
Yeah, I mean, look, I think the one thing great about New York is, and New York went through so much, and it's so grim, and it was so grim and so horrible, and we were just, in California praying for our friends and family in New York. But New York, it learned its lesson, and it was a terrible lesson to learn. And so the New York is going very, very slowly out of this. And that's the absolute right way. Because the truth of the matter is, from what we know right now, right, even in New York, the vast number of people are still, not immune, and we don't even know what immunity means in this virus, but haven't been exposed. The vast number, even at 21, maybe even 30% prevalence, antibody prevalence, that's 70% of people not having been exposed, and those 70% are still vulnerable. The virus, look, we can get the virus down so that the odds of exposure become so low that you can live a relatively normal life. That's the first thing. You got to get the odds down so that if a person is infected with COVID, their likelihood is that they'll infect less than one person, right?
Right.
Reproductive rate and COVID came into the US with a reproductive rate of somewhere around 2.5. So out of 100 people with no COVID, if you have COVID, you would infect 2.5 people. Measles, 18, by the way. So measles is much more fast spreading, but
Right.
it's a numbers game. New York is also huge. But I think what's happening in the middle of the country now, and what happened again in California, is that we had very few people exposed, right? Probably our surveillance study will come out soon, but LA and Riverside, they're all hanging between 4 and 6%. That means 92% of the population hasn't been exposed, right? So you can't afford to have a virus out there, even in small, because it can grow very quickly. And that's the problem, even in rural America, in middle America, is that they're naive, their bodies are naive in terms of never having seen this virus, and so everybody is vulnerable. So we have to be very careful. And when we open up, we now know something else about opening, right? We were talking about this before, and that's food. Food, it's the great experience of food, family, friends, dinner table, especially in New York, eating that wonderful food, is really a no-no. It's a great place to spread COVID, unfortunately. And so we have to open up slowly, and we have to maintain, vigilance as we open up.
And I think this brings me to, I kind of had a follow-up question there is really, I'm sure that there's many parents on here as well. And, schools here in New York, they have decided to reopen schools all throughout. Colleges apart, but many K through 12 will be opening for the fall. We've already seen it in many parts of the country as well. Is that really whether it's California or New York, what is the right information about that? And is it safe ultimately to send your kids to school?
Yeah, so that, it's complex. We just presented to the Orange County Board of Superintendents of Schools a couple of weeks ago. It's complex. The first part of the equation is, where is the virus on that curve? What is its sort of reproductive rate? How prevalent is that active virus in the community? That's the first thing. And if you are on an upward trajectory, right, and there's all different mandates about that. So percentage positive, so the number of people who are having tests over the number of people who are getting tested. If you're at 8%, 9%, 10% of people are still testing positive, and that positive or more, and that positivity rate is not declining, right? You really shouldn't be opening schools, okay? You want the number to be stable and declining, okay? And that's because you don't want transmission in that, because what you do in the school is definitely affected by what the transmission rate out in the community is. And we don't have closed communities, so people are traveling in and out, right? So Long Island, for any of you, Long Islanders, in New York, right? So Long Island, you go to school there, but your parents most likely are getting on a train and going to Manhattan. And so there's a lot of exposure. So that's the first thing. And then the second thing we know is that we don't, this virus, loves dense communities, right? Nothing more dense than 35, second graders in a classroom, right? Who try to follow the rules, but it's hard. And so, you've got to prune them. You've got to stagger, and I think some of the school plans have been really good. The thing about schools, though, elementary schools, is that the majority of students will be asymptomatic or have very mild symptoms. They transmit virus. And so to transmit virus to a 5-person household that's multi-generational with grandma and her multiple comorbidities is really problematic. To transmit virus to, the teacher who's going to retire next year, again, who maybe is home with somebody who has multiple comorbidities or, some kind of a compromised immune system, or is living with her daughter with a newborn baby. That's problematic. And so those are the things that we really have to grapple with. But School is a very important thing. And as we think about disparities, very important, you know, when we talk about social determinants, we talk about things like education as a social determinant. And so there is no doubt that this disease not only affects the poor and Latinx and Black populations, you know, disproportionately, but that the effects of this are going to be long lasting. And so the very students that need to be in schools, that need to have lunch in schools provided for them, that need to have that extra support are not getting it. And again, are often in homes that, or could be in homes that are not food secure, that are, you know, maybe there are other issues in the home, maybe there's abuse in the home. And so it really, it's not an easy decision to open or not to open.
Right. And, you know, just as I toss back to Raj, I think I just, you know, another thing I think is really important that really doesn't get talked about is the science is also not the speed of light. I think, you know, as somebody who's working on COVID studies in New York and throughout the country, you know, even just talking to my own colleagues or, you know, other people in the healthcare, you know, they're kind of all like, hey, you know, what's the new update, or, you know, what's the new information you have? I'm like, it unfortunately does not move that fast. I mean, you know, as well as, you know, scientific validity in checking that, it's going to take time. And I think in the era of technology and having things so on demand, you know, I think science has kind of got mixed in that as well. And that's what we kind of expect. But Raj, go ahead.
Definitely. I was just wanted to add to that comment saying that, you know, we can post about our $1 New York pizza on Instagram faster than we can find a vaccine for COVID. And that's the analogy I was thinking about. But my next question is actually something that's been asked in the chat, and we have a very live and exciting Q&A going on. So I'm just going to go through the first one, and Pawan, I'll revert back to you for the second one.
Of course.
And this is about, you know, you mentioned that this is a pandemic, but it's also been described as a political disease. So we're wondering if there are any historical examples that you can connect of pandemics that were also political diseases.
I'm sure plague was a political disease, you know. I'm a sort of an old a historian and microbe, you know, hobbyist. And, you know, so when people ask about, you know, or I ask, well, why was it that Rome fell, right? And, you know, most of the history books say, well, there was plague. And I've always said to myself, exactly how did that happen? And now I have a sense that I understand the way that something like a disease like this, unknown, devastating, although not as devastating as something like Ebola. So just try to remember, 75% of people die of Ebola. We are nowhere near that. But what's happened is that I think that it's been a political, so I would say, you know, that's one example. There were, if you look at pandemic of 1918, there was a lot of interesting politics going on. And in fact, you know, there's some interesting work that looks at our soldiers who all had flu, who were sent onto the battlefield, right? So what was that about? I mean, there's some politics going on there, and didn't survive, and led to these huge numbers in terms of, you know, deaths from the battlefields, but were actually influenza. And so there's and HIV, there was a huge amount of politics. If you remember with HIV, it took a community, which by the way is what it's going to take here, many communities around this country, to take control of this disease. And that's how we're gonna halt this disease. It's really gonna, but it took a community of HIV advocates to demand that the Food and Drug Administration change the timing associated with approval of drugs. And so all of these huge plagues, if you will, have had a huge political element.
Going right off of that into some of the other questions, I think more broadly speaking, I think there's a lot of, I guess, misinformation or lack of information. This is kind of a two-parted question. First of all is, a central, as we mentioned at the very beginning, a central communicator, a figure of, COVID essentially, right? I guess Dr. Fauci for that point. But, when we take into consideration, the information we've received about antibodies, antibody testing, regular testing, what should people really actually know in terms of that? And should they be getting tested for antibodies? Should they be getting tested regularly? I think that, from what we're seeing in the chat, and, I think just generally, people don't have a clear understanding. If they get the test once, are they good? Do they need it multiple times?
Right. So obviously we have two kinds of tests, right? We have a test that we use to help diagnose COVID, and that has been still nasopharyngeal swabs, right? It's a PCR test, and it tests for the presence of active virus. Now, there are a number of other tests that have been proposed, including saliva, and that would be fantastic because we have a lot of problems with reagents, with the swabs. We've had these huge problems in terms of preparedness for everything associated with testing. That continues, but right now, it's still nasopharyngeal. It's still the swab. You should stay home and call your doctor if you have any symptoms. And there's now a long number of symptoms, right? That's what you should do, right? You know that. And then they triage you and hopefully it's nothing, but if they feel that you need to be tested, you should be tested. Now, in the very beginning of this, a lot of people were doing that, and they were doing the right thing, and they would call their health provider, and their health provider would say things like, "You're not sick enough," because they were worried and they were rationing. And I think that was a real problem. And I still think it's a problem because we know that the symptoms vary from none to, emergency, hospitalization, intubation, death.
Right.
So I think testing is a really important component of this. And, guidelines now for higher education are talking about asymptomatic testing, but that's what we're talking about. We're talking about looking for active virus. Now, the moment that you have active virus, or someone with active virus, the next thing that's supposed to happen is that local healthcare agencies are supposed to start contact tracing. It's critical. Testing, isolation, contact tracing. It's the only way to halt this virus. So that's kind of one testing component. And if you were a direct contact of somebody, so what does that mean? That means that you've spent at least 15 minutes within 6 feet of this person over the last 14 days, okay? So not everybody. So that doesn't mean if you're in the same room, but you're in a far away place or at the other end of that subway car, likely you have not been in direct contact. But certainly if you're in that same space, working together, eating together, you would, and then on that testing, because I'm going to go to antibody testing in a minute, but on that testing, the other important thing is when you get tested, right? So if I have COVID and I give it to you, Raj, okay, and you get tested the very next day, sorry, wouldn't happen because we're Zooming, but the very next day, you might have acquired COVID, but you're not at the point where you would test positive yet. And so the testing, if you've been exposed to somebody who has COVID, the recommendation now is going to come in at something like at 7 days. But here's the tricky part. You need to be home for those entire 7 days before testing, and or if you have experienced symptoms, get tested at the point that you've experienced symptoms. So that's all very complicated, and that's just for active testing. And I think in New York, from what I'm hearing at commercials now, public health commercials, that people have access to testing. Is that true, New Yorkers? Is that true? But
I would say it's been throughout the majority of Manhattan, yes, parts of the Queens, Bronx, other parts of lower Manhattan. I think, they're gauging also the population that's still even there. And also, I think there's just that barrier of, community acceptance or trust toward the public health officials, or, even the government.
right. So, but at least having access. I don't think that access is good enough yet in Orange County. There are a few companies that are coming out with point of service testing, which would be really great. It's like finger stick. Now they're not 100%, but they're good enough to get most people. If you go with symptoms and testing, you're going to get pretty good coverage. And that's active viral testing. Now let's go to antibodies for a minute. And this becomes extremely complicated, okay? So a couple of things. First, the Food and Drug Administration, under emergency, in an emergency climate, has approved a number of tests for COVID. Are they the most sensitive or specific, to use public health terms? Let's translate it to accurate. And sensitivity and specificity have to do with the number of false positives and the number of false negatives, right? And so, and you would rather have too many false positives, right, than false negatives for COVID. Why? Because you don't want somebody you don't want somebody who has COVID sent out feeling that they don't have it when they do, right? So these tests, though, and we have different kinds of antibodies that we develop, right? IgG, IgM, and this new one, if you're into this, is neutralizing antibody, right? Which they think now is very important, okay? But that's only from a few pieces of literature. I've been trying to figure it all out. I believe IgG seem to be better able to detect active, that you've had exposure than IgM, okay? But the tests are very, very variable. And now it seems like people who had COVID early, and now remember, some of the evidence suggests that COVID was around a little bit longer than we thought. Maybe certainly December, maybe a little earlier. And if you were a traveler into China or Asia or other places, maybe even earlier than that, you may have had COVID. You may even remember this terrible experience that wasn't flu, but what was it?
Right.
And your antibodies may be negative because it just may be that the duration of time. I think antibody testing is really important from a population perspective. It's important to get a sense of the prevalence. I think that all antibody testing that we've done for COVID is an underestimate of COVID in the community, but at least it gives us some place to start with, okay?
Right.
And so I think that antibody testing is good from a population perspective, but less accurate still from an individual perspective.
Raj?
Yeah.
Perfect. That was really informative. So thank you. On that topic of community and testing, one of the really interesting questions we had in the chat was around, what are the happenings around marginalized communities and testing and the lower testing cases and sort of the practices in place, and sort of how can we address them? How can we sort of work towards increasing testing in those communities?
Yes, so I think that's a great question. And again, back to, it's communities are organizing now, thank goodness, and working with places like UCI, where We're very organized and integrated now with Santa Ana and Anaheim, and there it has to be a multi-pronged approach. And so we have to think about what are the testing facilities in the neighborhood and who has access to them, right? So is access only through private insurance? If I don't have private insurance, but I have some insurance, what's my access? And if I have no insurance, can I get tested? And what does that look like? And I think that the no insurance is really important, that that local government should be asking their state for money to test those people that do not have insurance. That's one thing. I think we have to spread the message again of who should be tested. People should be symptom checking every day in places where, you know, the positivity rate is higher than maybe 5% and rising, especially in your communities. People should be symptom checking, and they should be getting tested, and then contact tracing should happen. So in Santa Ana and Anaheim, we are we have put the first health equity contact tracing workshop together. It is being attended by, it was 700 people had registered for it at UCI. It's virtual, and a number of those people are health promotores from Anaheim, from Santa Ana, and they are helping the contact tracers to follow up on cases. Santa Ana and Anaheim have employed high school students who are, anxious to be involved in this, to help talk about how to stop transmission in households, in large households where there are essential workers, where somebody in the family is getting exposed, coming back home, bringing it home. How do we stop that transmission? And so we've been educating high schoolers to go into their families and their networks and really try to do that. So it's not just about testing, but the message there again is symptoms and testing. So, so we need to again, identify the hot zones and identify. So some of the issues were, I can't be isolated from my family because I can't pay for a hotel. I have no food if my husband doesn't go out and work. He's working as a, unskilled, semi-skilled. If he can't take sick time, there's no such thing as sick time. So last thing, the actual policy of social distancing created, from my perspective, created greater disparities, right? Because those that could work from home, who could afford to be home and ordering in food, did, but those that could not, didn't. And so they ended up with all of the exposure, and then came back living in the densest communities, and you ended up with this catch-22.
So I think the other, just looking at time here and everything. So as we, continue to move forward through this, I know here, at least in New York, one of the things I'm part of is it's a COVID registry study. So we'll be evaluating long-term effects. Mount Sinai is the first to launch such a study to really see what those impacts are going to be, especially in patients who, have underlying respiratory illnesses or other comorbidities. And I think, as we kind of head toward this reopening and, whatever phase, whether wherever you are in this country, what would you say to the people who are still trying to be health conscious and, who are trying to stay positive with the headlines that constantly come out about COVID?
So I think there's a couple of things. This is a disease that it just came out from Los Angeles County, but that 92% of people with significant COVID had other comorbidities.
Right.
Two things. One, this is the time now, take care of yourself. If you have hypertension, get it under control. If you have diabetes, if you have asthma, it's critical that you keep control of those things. critical. That I think is the first thing. It's hard not to gain weight. I was on the phone with somebody, I don't know, the COVID-19, right? Like the 20 pounds you gained at college, the 19 pounds you gained during COVID, because everyone's become a baker, right? Cooker become
Right.
chef and baker. But depression is really important. It's everything to do with not getting out, not being able to socialize.
Right.
People who have underlying depression, you need to take care of yourself. It's important. If you're in a bad situation, get out of it, COVID or not, get out of it. And that's what and talk to somebody, get help, seek help. Resources are there. It's really about taking care of the whole self. At the same time, it's harm reduction. And COVID is there, but there are other components of people's lives, and they really need to get through this. They need to be as well as they can be.
Of course. And I just want to see if, do you have any last words for everyone here today?
I mean, I thank you so much for listening, for being part of UCI alumni. UCI, you should be proud of your institution. They are doing everything, not just for the students and faculty and staff, but for the community. We are working as fast as we can to make a difference for everybody. You should be so proud of that. And you should all stay safe and stay well. And it's really been my pleasure speaking with you tonight. Take care.
Of course.
Thank you so much for your time
joining
today.
us. It was wonderful to have you, and I'm sure we'll be talking more about this sooner than later. But
Yes, this recording will be shared with everyone for the
of
question.
course. With that, to everyone who's on this call, I just wanted to share, you'll be receiving an email later on with some of the points we discussed here tonight, as well as other ways to stay in touch with the New York chapter here, and most importantly also during this time, staying in touch with the public health